Thank you for being here again today for our Center on Aging and Health Scientific Seminar Series. And as most of you know, we're very lucky to have funding from the Matthew Tabak Memorial Lecture Fund that provides funds for us to bring in external speakers like Dr. Gaugler. And so I'm grateful, and one of the things that we kind of take for granted, but it's good to be able to invite speakers in and buy their plane tickets and even take them out for dinner. So we'll be doing that. I also want to announce that we have our next talk lined up already and try to stay at least 1 month in advance. And thanks to Michelle Carlson and others. We have Sarah Shizuko Morimoto, Associate Professor with and the Director of Cognitive Rehabilitation of the Department of Psychiatry at the University of Utah. She's going to be here on Monday, May 7th. And the title of her talk is going to be Computerized Cognitive Remediation for Geriatric Depression. So please try to put that on your calendar to be here for that talk. Today we're very fortunate to have with us Dr. Joseph Gaugler, who's the long-term care professor in nursing at the School of Nursing at the University of Minnesota. I've actually known Joe for about 15 years, I think. We started working together both as co-investigators on a project directed by Mary Middleman at NY University. Mary has done some really landmark work looking at the spouses of people with Alzheimer's disease. I was one of the original investigators looking at interventions for dementia caregivers. And Joe and I both joined at different stages of her program to help her analyze data, write papers from that, get renewals and so forth. So it was in that context that I first met Joe, and I've stayed in contact with him ever since. So he's a long-term colleague of mine. I've been very fortunate to work with Joe on many projects and papers. Multiple grants, and we have 2 grants, or he has 2 grants that he is the PI or the co-PI on right now, and in both of them he's employing myself as well as Jen as his statistical team. So we're looking forward to many more years of working together with Joe. I found Joe to be one of my most enjoyable and stimulating principal investigators that I get to work with. So just a little bit of background. He got his bachelor's degree from Gustavus Adolphus College in St. Peter, Minnesota, and double major in psychology and history. So another guy with a psychology degree, so we allowed him into the seminar. He then went to Penn State and got master's and PhD degrees from Human Development and Family Studies from Penn State. After Penn State, he went back to Minnesota, this time at the University of Minnesota, where he did a postdoctoral fellowship. From there, he went to the University of Kentucky as an assistant professor in the Center on Aging and the Department of Behavioral Science, but couldn't get Minnesota out of the system. So after about 5 years of Kentucky, was able to get recruited back to the University of Minnesota as an assistant professor in their School of Nursing and the Center on Aging there. He has since been promoted to associate professor and now full professor in the School of Nursing. Joe's, published a lot of papers, a lot of very highly cited papers. Is really a leading expert in a number of things, particularly long-term care and transitions from community to assisted living or nursing home placements, and how to support families as they're contemplating those transitions and looking for the predictors of those kinds of transitions. He's also become a leader in looking at and implementing technology to assist families who are trying to live at home, and I think that's going to be part of this talk today. Joe was gracious enough to serve as the discussant when we had a symposium for a Roybal Center out at San Francisco this summer. Joe was our discussant, and without looking at anything ahead of time and without taking a single note, sat there and listened to all the presentations and got up and gave a very, I think, helpful and synergistic discussion. So I was, I knew you were smart, but didn't realize you were that good on your feet that quickly. I usually got a little bit of preparation. And because he did such a good job last year, we've asked him to be our discussant if we're lucky enough to have our symposium at this coming GSA, except he's going to be our discussant for that as well. He's been on a number of editorial boards. He was the longstanding editor-in-chief at the Journal of Applied Gerontology, and probably remembers, although maybe not, but he's even rejected a few of my papers when he's tried to publish things in the Journal of Applied Gerontology. So he has high standards and can find ways to even reject some of his good friends. But anyway, he's currently on the editorial board of the Journal of Gerontology, Psychological Sciences, and Social Sciences. and has served as a member of a number of study sessions, including the Veterans Administration Health Services Research and Development Review Board. So anyway, it's a pleasure to have you here, Joe, and the title of your talk today is Cyber Security Blanket, or simply another stressor, remote activity monitoring for people with dementia and their family caregivers. Welcome.
Thanks, David. Well, David, thank you so very much. Can everyone hear me okay? So, David, thank you very much. I can't tell you what a thrill it is to be here at Johns Hopkins. There are so many long-standing colleagues had a chance to meet here today, friends, others, and again, it's just a real pleasure. It is a bit intimidating, I have to be honest. I'm hearing all of these priority scores on big scale grants you're all getting, and then I go home and I see my priority score. I feel like I'm there to pick up the crumbs after you. But in any event, it's been great to talk with many of you, hear your ideas, and hopefully forge continuing and maybe new collaborations too. So again, thank you for this opportunity. I wanted to acknowledge a number of people and funding sources for some of the material that you'll be hearing today, primarily my research team, who you see on the screen here. The work that I'll be presenting here today was funded by the Agency for Healthcare Research and Quality, first and foremost, through its R18 mechanism, which is kind of an interesting mechanism. It's funded at the same level as R01s at AHRQ, but it focuses on what are called demonstration grants. So really demonstrating work and research, particularly health services or even interventions in kind of real world community or clinical context. And this is a study as one example. And then also this K2 mechanism, which funded me several years back to obtain some at least baseline expertise in mixed methods, which also is going to be a feature of some of the work that will be presented today. And again, many of the team members on this screen here have contributed to the work as well. And I really wanted to point out the Lutheran Home Association and Sharon Bloom. This work really grew out of a community partnership I had with the Lutheran Home Association, which is a long-term care provider in a town called Belle Plaine, Minnesota, which is around 40 minutes south of the Twin Cities. Really a rural long-term care provider, but probably since 2009, 2008 have been implementing this technology of remote activity monitoring within their nursing home, assisted living setting, and independent living settings as well. And that's where I first became exposed to remote activity monitoring, at least in a residential care context. And that's what kind of led to the HRQ proposal, which wanted to determine, can this kind of technology work in the homes of people with memory loss and their family caregivers too? Oops, here we go. Okay. All right, so what are the aims of this presentation today? It was somewhat, I think, ambitious of me to try to do this, and I'm going to do my best to get it all squeezed in by, 4:30 or so. But really what I'm doing is presenting to you the results of two studies based on this project. The first is really a study of acceptability and utility. What we did was we took the data we had collected for up to a year and a half of a small subsample of our parent study of remote activity monitoring. And what we did was utilize a number of quantitative as well as qualitative data elements to better understand how did family members really accept and receive this technology, this remote activity monitoring technology, or RAM we're going to call it for short. And really, how did they adapt to this technology over time? That was really the goal of this first paper, to get a better sense of what were some of the barriers and challenges to use in everyday context, the everyday home context of people with memory loss. So this paper was just recently accepted in the Journal of Applied Gerontology. And then the second study, and this study is currently under review at the gerontologist, which is basically, I would basically call it a preliminary effectiveness analysis, where we took and examined 6-month caregiving outcome data on our parent study sample to determine whether RAM technology actually improved caregiver self-efficacy and competence, and then as well as reduce caregiver distress. And I use the term distress as a global term. It really represents subjective stress related to care demands, then also depressive symptomatology as well. So what you kind of see here is the initial evolution of the study, starting with an acceptability and utility analysis, and then moving to actually looking at, does this technology impact key outcomes, in this case, caregiving outcomes. I don't think I need to spend a whole lot of time on this, since many of you have probably contributed some of the main papers describing this issue as a public health concern. But we know that close to 6 million people in the U.S. have Alzheimer's disease or related dementia, depending on the, of course, source you're looking at. And with that in mind, over 16 million family members care for these individuals. The majority of care is provided to persons with Alzheimer's disease or related dementias is provided by family members or other unpaid sources. And then that family care is valued at $232 billion. And I always include that statistic in my presentations because it's kind of interesting when you actually think about it. When you take that value, that annual value, which is essentially how much would it cost to hire a home health aide or similar professional to provide care to somebody with Alzheimer's disease at home. If we had to pay for that, it would be valued at $232 billion roughly. That's essentially, I think, 8 or 9 times the revenue of McDonald's in 2017, and it's something like half of Walmart revenue or something like that. That gives you a sense of the reliance we place on families to provide care and assistance to people with dementia in this country. I actually looked at this specifically in Minnesota. I testified in front of the Senate Committee on Long-Term Care, if I recall. And I actually looked at Minnesota alone, which has, I'd say, around 225,000, 230,000 caregivers estimated. If you take that value, it ends up being like $1 billion or something close to it. It basically puts it in a Fortune 500 company category in terms of revenue. And that's just for Alzheimer's care alone. Clearly, you can make the case compellingly, when we talk about long-term care, it's really family caregiving in the U.S. It certainly is the most major component of long-term care that's delivered in the U.S. And certainly numbers like this provide evidence for that assertion. So a couple of years ago, my colleague, Dr. Bob Kane, and I co-edited a book called Family Caregiving in the New Normal. And actually several people, or at least one person from Johns Hopkins contributed a chapter. That was Jennifer Wolf, who did an excellent chapter on chronic disease trends in family caregiving. But really the whole point of the book was trying to get a sense is that, number one, is this over-reliance on families sustainable in the United States? And number two, are there any solutions to overcome what we would call an impending family care gap? So when I kind of stepped back and looked at this book, I mean, I thought it came together. We had some great contributors and great chapters. I think it served as a powerful precursor to the 2016 report that came out from the National Academies of Science, Engineering, and Medicine on family caregiving in the U.S. But I felt the book itself did a good job in highlighting the threats to family caregiving, the various trends that are occurring, socioeconomic, health, et cetera. But didn't do as good a job in really highlighting potential solutions. It seemed very piecemeal, and maybe that's just a state of where we're at as a society and how we're going to help and support family caregivers. You know, we had a chapter on policy, we had a chapter on services, a chapter on translation, et cetera, but there wasn't really a cohesive solution provided on how we're going to sustain this potential drop in families in the future. And when I say potential drop, there's a well off-cited statistic where if you look at the number of family members available for older persons in need of care, I think the number right now is something like 8 to 1. It's something like that. There's around 8 family members or so available to provide care to older persons in the U.S. By 2025, that number is going to drop to something like 5 to 1 or 4 to 1. So you already see in pretty stark terms that because of various socio-demographic trends, whether it's the birth rate, women's increased participation in the workforce, et cetera, we cannot continue to rely on family members to do the care we're asking them to do. Okay, so what can potentially offset that? Well, one potential solution has been technology, and it's been proposed in a variety of different ways. And we've had some interesting conversations actually earlier today in thinking about technology in this space and in terms of research in technology and aging. I mean, I want to be clear, and I believe this, I am not, I guess, an acolyte for technology necessarily. I mean, what is technology really as a term? I mean, what is it? I mean, we think technology, we think high-tech gadgets and such, but you can make the case technology is really anything that can actually help supplement, help someone adapt to their given environment to perhaps live a better life. But with that in mind, what are some emerging technologies that could potentially offset this family care gap? So we had a great chapter, again, written by a leader in this space, George Damiris, who basically provided us a chapter on smart home and other types of technologies and their implications for caregiving. And I apologize if you can't read that slide very well or that table, but here you see some of the various types of technology domains that exist and what some of their implications are for caregiving. So for example, I'll pick out one row here, safety monitoring, which is collecting and processing measurements that detect environmental hazards such as fire, gas leaks, etc. And what could be the implications for caregiving of these technologies would provide peace of mind for caregivers. You can see other various types of functions that different types of technologies can actually provide. Now, one of the things I think is important to note is when we talk about technology, and talking with some of you, I think this was evident as well, is I kind of group the science of technology and aging in two really gross domains. One is technology as intervention, which I think this table more or less illustrates. Technologies that can directly intervene with the idea that it will improve some type of outcome. I think the other way to think of technology broadly is technology as advanced data collection, pushing data collection forward, giving us real-time massive amounts of data that can then be mined, utilized to develop predictive algorithms, et cetera. That again, one would hope would lead to some type of positive clinical outcome. But when I take stock of the technology literature, that's kind of how I see it. I mean, kind of in these two domains. Now, they certainly are not mutually distinct, but nonetheless, that's how I see technology and aging being used in one or the other per se. So today's talk is really, and this is how I approach it, is thinking of technology more as intervention. Do these technologies, do they do the things they purport to say to do? When one takes a sober look at the state of the science of technology and aging, particularly remote activity monitoring, one of the things I've noted is there's been quite a bit of work done on smaller scale feasibility, utility pilots and such, not many studies of outcome, very few evaluations of do these technologies actually help older people with memory loss stay at home for as long as possible. They're certainly being marketed as such to families, but do they actually accomplish these things? Do these types of technologies help family members feel a sense of peace of mind, a sense of security? Do they actually enhance their feelings of confidence, et cetera? We really don't have good answers to these questions at present. That was really the whole point of this project, was looking at this specific intervention, technology intervention, remote activity monitoring, to see if it would lead to positive outcomes in the space of home-based dementia care. So what is RAM? Essentially what RAM is broadly is includes systems comprised of video, audio, and or motion sensors that are capable of detecting activity in certain areas of the home. The information is transmitted to software and hardware and is analyzed for various purposes, such as issuing an alert when an activity crosses a threshold that is unexpected. So what this activity threshold is can be one of two things. One is an activity occurs that you don't want. Someone gets out of bed at a time that's unexpected. Someone opens a door at a time that's unexpected, et cetera. And then alternatively, the alerts are also issued when something happens that doesn't happen that is expected. For example, lack of movement. There is no movement in a room, say 20, 30 minutes, 40 minutes, the system that can issue an alert as well. Many developers of this technology, and certainly some researchers as well, believe that RAM can allow healthcare providers or family caregivers to detect these abnormal activity patterns and then allow for responses that are more proactive and efficient. So that's kind of the premise of why these technologies are thought to work. So in terms of the state of the science, which I alluded to earlier, certainly older persons themselves are interested in the potential of these technologies. Some preliminary studies have seemed to suggest that these technologies can contribute more accurate information on activities and perhaps other caregiving domains as well. At the same time, these studies have also highlighted a number of barriers to implementing RAM technology. They include cumbersome devices, a lack of user-friendly interfaces, particularly in trying to understand this activity pattern data that's being provided. I mean, you can see the data, but what does it mean? How do you intervene on it clinically? When do you intervene? I don't think those things are always clear in many of these particular systems. Another big issue are frequent false alarms. Many of us in technology and others may worship at the altar of the algorithm, but nonetheless, in real day-to-day experiences, sometimes these systems aren't calibrated or set up appropriately for that given context, particularly a home-based context, and then frequent false alarms can result. And then finally, unanticipated technological difficulties ranging from things like sensors not operating to difficulty for users to actually troubleshoot. I mean, these are all various barriers that can occur. Finally, there's this trade-off between privacy and usefulness of monitoring as really an ethical issue. I mean, in Minnesota, there was a recent expose that occurred in the Star Tribune, which is the main paper from Minneapolis. I think a 6-part expose on basically elder abuse in residential long-term care. And what some of the stories were focusing on were families putting cameras in their loved ones' nursing home units to find and identify abuse occurring. And so at one level, you say that's right and that's good because it's detecting abuse when it's otherwise not reported, and that's important. But then thinking of it in a different way, nursing homes already are regulated to a great extent. It's already difficult to maintain the direct care workforce in these settings. They're not getting paid very much to begin with. If you start putting in cameras and other types of remote activity monitoring devices that watches every single little move and every kind of care activity provided, who in their right mind would want to work there? I mean, think of that. I mean, when you flip both sides on both sides, this to me is the complications of technology, not just in a scientific space, but in an ethical space as well, and a policy one too. I don't think anyone here would say, you know, things should go as is and, you know, elder abuse is just a byproduct. That no one would say that. But at the same time, I think these are complicated issues that need to be considered and addressed. So as I mentioned before, there really are very few randomized or quite frankly controlled studies of the effectiveness of RAM, particularly in the dementia context. Those that at least our team was able to find tend to be smaller. They do suggest potentially positive effects of RAM for family caregivers and older adults over roughly 6-month periods or so, and they tend to show good effects on caregiving outcomes too. Now these type RAM often in these studies tend to focus not just on RAM but then additional support that's provided as part of RAM. So an interesting contrast in our study was the fact that we provided RAM for families to use themselves, and alerts were directed to families. In many of these other studies, the RAM technology actually directed the alerts not to the families necessarily, but to some type of care professional. Certainly in the community, it would be a care planner, care manager, or something like that, which I think is an interesting context to reflect upon as we see the results later. One of the better studies that occurred of RAM was published recently in the Journal of American Geriatric Society. And it was a larger controlled evaluation, and they were actually specifically looking at healthcare costs. And they found that RAM did seem to have positive trends in reducing healthcare service utilization and other types of related costs. One thing that's important to note, though, these results were not statistically significant, but nonetheless, the trends seem to be going in the right direction. So in a nutshell, what are the gaps here? Small sample sizes and short periods of observation. More research is needed to really understand how families adapt to RAM over time. How do they view the acceptability and utility of RAM over time? And then finally, there's a lack of controlled outcome evaluations. And that was really how we proceeded with these two studies, and these were the gaps that these two studies were designed at least partially to address. So the RAM technology in our particular study, we call it eNeighbor for short. So what eNeighbor is it consists of 6 unobtrusive motion sensors. They're placed in various parts of the home. The sensors don't have cameras in them, so they don't record video. They don't have mics in them, so they don't record sound. What they do is they track motion and activity. This is considered a smart sensor system. So what the system can do is it can learn activity patterns, and then it can issue alerts when, again, certain activity thresholds are crossed that are considered unanticipated. So it can do that itself, but then families can also customize the system to monitor certain areas, monitor certain times, et cetera, as needed. So the system itself is fairly customizable to the needs of families and people with memory loss, depending on what the monitoring needs are. So this is a picture of the sensor system. You can see it there on the upper left-hand side. They include sensors that can go in rooms that can track motion and activity. There are sensors that can go on doors. There's a sensor that can go underneath a bed mattress that determines whether someone gets in and out of a bed. There's actually this one right here on the lower left-hand side is kind of interesting. This is, whoops. I don't know if this works. I'm sorry, everybody. Well, in any event, you can see this one right here. This is actually a sensor that goes in the toilet, kind of, in the basin there, and so it detects how often the toilet's been flushing or not. And then there's also an option to wear a pendant as well. That can be a pressable button, but the pendant also has a sensor on it as well that can detect, for example, someone leaves a doorway or leaves the home or something. So that's basically the system itself in terms of the sensors. And then on the right-hand side there, you can see kind of the information that's provided that's available on an online dashboard for families to monitor in terms of various types of activity patterns, when alerts are issued, et cetera. So the monitors have these various functions. They include passive check-in, this out-of-bed sensor, which we've talked about, or in the bed too long, whether the front door of a home opens or not. This, of course, is used to detect potential wandering events. Nighttime bathroom activity. So this alerts a caregiver if the person needs assistance at night in the bathroom. And then, of course, alerts if no activity occurs and it's expected. So these are some of the various potential alerts that can occur in the context of this particular system. And then finally, here are just some more details about the dashboard itself. It flags changes in various activities of daily living. It can separate day and night, and it can offer data from the last 60 days. And then also a 7-day moving average is provided as well. Okay. So that in a nutshell is the technology itself. We did not develop the technology. It was developed by a company called HealthSense, which is located in Minnesota, and now it's called Great Call. So, but this is, and I think it's similar to other types of monitoring systems. It may even be considered somewhat out of date at this point when you look and see some of the other sensor systems that are available, which is a market that's evolving rapidly to the point where, again, Fortune 500 companies are starting to move into this space, like Google, like Best Buy, and others as well. And finally, you can see another picture of the dashboard here. This is a 24-hour activity timeline. Okay, well, we go from nice pictures to this one, which isn't so nice, but this essentially, this is, for those of you that know about mixed methods or have been utilizing it in your studies, one of the things I found most helpful in books by Cresswell, who's kind of known as one of the leading mixed methodologists in the US, is how much he and his colleagues emphasize figures to document mixed methods designs to help people better understand what's being done and when. And so this, in a nutshell, summarizes what we're doing in this parent, what we call embedded experimental mixed methods design. We call it embedded because it has elements of the kind of the classic randomized controlled evaluation, but embedded in that are various qualitative components to better understand processes, mechanisms of benefit, acceptability, utility, et cetera. So if you take a look at this figure, you can see in the upper left-hand side, essentially the framework for the randomized controlled evaluation, where we're going to follow family members over an 18-month period, family caregivers in particular. We administer surveys, online or mail, baseline, 6 months, 12 months, and 18 months. And you can see there the various outcomes we're going to be analyzing as part of our parent randomized controlled evaluation. You can see in the product, those will be some of the types of analytic approaches that we're going to be applying to these data. But in addition to this, there are various qualitative components we're including. The first I'd like to point out is what we call this embedded process evaluation. I guess is a good word to decide. I couldn't come up with a better term at the time. But basically what we do in addition to collecting this data is every 6 months for those in the treatment condition, we administer what's called a RAM review checklist. So this includes around 22 Likert survey items that we developed ourselves that just gives us a sense of how well our caregivers receiving the technology or not. You know, what are the barriers? Is it easy to use? Is it confusing, et cetera? But then in addition to that, we also provide 6 open-ended questions that caregivers can provide qualitative comment and data on, again, how well they felt the system was working for them or not. Okay. So that we do every 6 months up to the 18-month interview. And then also, at the end of the 18-month participation, we then conduct a stratified purposive sample where we identify family caregivers who indicated high acceptability on these system review checklists via the Likert scales averages, and then those that didn't, and then we conduct a semi-structured interview that consists of around 10 to 12 questions, but again, allows us to get a little better, get more in-depth information as to why was this working or not, you know? It allows us the opportunity to move beyond whether something works and then answer the questions how and why it works, you know? And when we look at the state of the science of dementia care intervention, maybe in non-pharmacological dementia interventions, et cetera, this whole question of process to me has been woefully understudied. We don't know why these interventions work, and but maybe more importantly, we don't know why they don't, because a lot of them don't work at all. You know, if you think about it, if not statistically, clinically. So that's why I have gravitated more and more to mixed methods in a lot of the work I'm doing. And certainly some of the work I'm doing with some of you in terms of the ADS Plus project, in terms of our project, David, the randomized or the residential care transition model, it shares very similar elements to this. Okay, so let's move to study number 1. And so what study number 1 was, at the time we did it, we wanted to look and, again, try to get a better sense of what is the acceptability and utility of RAM. So at the time, and you'll see this a little bit more later, we had roughly 30 caregivers that we wanted to include. They were randomly assigned to receive the RAM treatment. And all of them had provided at least 6 months of data, but in several instances had progressed even farther along in the study. They had completed not just 6 months, but the 12-month interval, 18-month interval, and even in some cases, they completed semi-structured interviews. We wanted to marshal all that data together, both quantitative and qualitative, and really implement this kind of mini mixed methods study, which I think you can see it's called different types of designs, but it's really a concurrent parallel mixed methods design. I think that's what Criswell calls it. But again, we use this diagram to give you a sense of what were the data we had at our disposal to actually merge and bring together to get a better sense of how well the RAM technology was used. So in terms of quantitative data, again, we had the RAM review checklist only at 6 months for this particular study. Okay, we had the 6-month data. But then in terms of the qualitative data, we had up to 18 months of both the review checklist open-ended comments as well as the semi-structured interview. The reason why we limited the empirical data to only the 6-month RAM review checklist is at 12 months and 18 months, there just weren't enough people for us to do any kind of meaningful empirical analysis. So we kind of just we truncated the empirical data collection for this particular study at 6 months. But then again, you can see what we did in terms of analyzing the qualitative data, quantitative data, and merging them together. In this case, it was really comparative, comparing the qualitative data with the empirical data to see where these two data elements converged or diverged. And by doing that, we felt we were able to achieve greater meaning in terms of the results we found, which again is usually one of the main reasons why one would want to do a mixed method study. So participants for this study, they were recruited via, we have a University of Minnesota caregiver registry, which includes at this point, around 700 family members and roughly 300 to 400 professionals who have indicated interest in learning more about our projects. So we recruited participants through that mechanism as well as through advertisements and other various multiple community outreach presentations that we do. You can see here the inclusion criteria for persons with Alzheimer's disease and related dementia. Unfortunately, we didn't have the translation capacity to include people who couldn't speak English. They did have to have a diagnosis of Alzheimer's disease or related dementia. And then we use as a cut point 55 years of age and over in terms of the sampling criteria. And then for caregivers, it's somewhat similar. Specifically, they had to self-identify as someone most responsible for providing care to the person with Alzheimer's disease or related dementia, and also had to plan to remain in the area for the next year and a half. So in our surveys that we administered over time, these are basically the empirical data that we collect. This study is more or less conceptually couched in the stress process model, which is based on this mechanism of proliferation. Stress from the day-to-day care that's provided to someone with memory loss spreads to other life domains. And these this spread of stress is then thought to impact more global outcomes, like, for example, burden, but also depressive symptomatology, and in some cases, care recipient living status as well. So these variables reflect some of the various domains of the stress process model, which you can see here. And then finally, you see that RAM, called the e-neighbor here, but the RAM review checklist, which was 21 items, which we developed specifically for this study, and actually showed good reliability as well when we did analyses in this particular project. Okay, so at the conclusion of the checklist, caregivers were actually asked 8 open-ended questions, and some examples here is: how was e-neighbor easy or difficult to use? Do you feel alerts generated by e-neighbor worked well? Why or why not? And then, as you saw from that earlier figure, we did these semi-structured interviews at the end of the 18-month participation for these purposefully selective caregivers based on their review checklist responses. So the data analysis for this in terms of mixed methods, in terms of the quantitative side, we're fairly basic. I mean, again, we only had 30 participants to work with. So we did descriptive analysis, particularly on the RAM review checklist itself. That was probably what we focused on most specifically. We did run bivariate associated correlations between the RAM review checklist score, the overall average of how well the system was received or not, and those various stress process model variables you saw earlier. Was acceptability related to dementia severity? Was it related to whether the caregiver lived with the care recipient, et cetera, et cetera? Then in terms of the qualitative data, we had at our disposal 7, at the time, semi-structured interviews, and then we had 56 open-ended surveys collected again at 6 months, 12 months, and 18 months. And these data were analyzed by 2 of my graduate research assistants. And so what they did was kind of a classic thematic analysis of this qualitative data. And then essentially what we did is we compared the empirical results from the RAM review checklist with these qualitative themes. So basically compare them side by side to see how well did the data triangulate? Did they diverge? Did they converge? And if not, why? And then also we conducted something which was interesting called a case-oriented merged analysis. And this is another example of a mixed method analysis. So what we did is we looked at some of the trends that were occurring in both the qualitative and RAM review checklist data over time, over the 18 months. And what we did was we kind of compared their average RAM review checklist score at each interval with some qualitative data elements. And basically we did that to identify cases in our sample. And you'll see here in a second what the results of that analysis was as well. So essentially what we were trying to do here was maximize our longitudinal data available with the qualitative and quantitative data available to give us a sense of what was happening over time in terms of acceptability and utility. I apologize, you can't see this very well. I wanted to show you some of the baseline descriptive characteristics, at least of this sample of 30 individuals. It was admittedly a very white sample in Minnesota, where most of our participants are from. The aging population, it tends to be predominantly white. And so that's definitely a major downside of this sample. But I was talking about this earlier. Later in the study in particular, we started getting more and more success or having more success in recruiting people from rural areas in Minnesota. We were finding many rural families were interested in this type of technology and implementing it. So I'm hoping at the end of this study, when we accumulate our full sample, which will be 200 families, we would definitely like to do some rural and urban comparisons as well. In terms of the overall dementia severity of participants, if you look under that primary objective stressors, you can see the St. Louis University mental status score. Again, this is a screener, so you can't necessarily determine dementia severity effectively with this, but nonetheless, the scores tended to be on the more lower end. Memory and behavior problems were, I would say, moderately frequent. Cognitive impairment in general was moderate to severe. That more or less is the sample. I'd say it's a pretty typical volunteer sample of dementia caregivers that participate in this particular study. In terms of disposition, which was interesting, again, remember, this is on the 30 caregivers that we focused on in the treatment group for this preliminary study. You can see here what happened over the 18 months. And really what you have are three mini cohorts within this sample of 30. You can see we had 13 people at the time we conducted this study who completed the entire project. They finished the 18 months and were eligible to do interviews. But over time, you can see what happened to the technology and why, in some cases, participants weren't using technology by the end of 18 months. So in some cases, in one case in particular, I remember this very clearly, one care recipient who had memory loss basically said, we basically obtain assent from the person with memory loss every 6 months to make sure that they still feel okay with having the technology in their home. And actually one care recipient who was fairly young, probably more of an early stage dementia individual, basically said, I don't want it in here anymore. I feel like I'm being watched all the time. So we had to remove the technology in that case. The study did follow intention to treat principle, so we continued surveying that caregiver regardless. In other instances, you can see care recipients dying or moving to long-term care over the course of the study. In some cases, the system wouldn't work in one person's home because of other interference from other kind of things they were using in the home. They weren't related to RAM, but they had other kinds of things going on in their home. The system just wasn't working. So by the end of the study, you can see 6 people were still using the system over 18 months. Over time, the number of people who were using the system got better, I think in part because of the degree of follow-up that the Lutheran Home Association was doing. Basically, when the system is first installed, what happens is Sharon Bloom from the Lutheran Home Association comes in and does a needs assessment, where she does a home assessment to see what the home is like, kind of, the basic orientation of the home, and then the needs of the person with memory loss as well. And then she sets up the system for families, and then she is there to troubleshoot. And I think initially when we started this study, even though Sharon was made available at any time for family members to call, we found many families just simply didn't contact her. So it was difficult for us to ascertain were there problems going on with the systems unless they contacted Sharon. So as we moved on in terms of delivering the study, and I guess this is just an example of when you do these types of evaluations in the real world, I have to kind of sometimes adjust even though you don't want to. in terms of when you consider this in terms of a classic trial design, is what we had Sharon do, as well as my research coordinators, is to be more proactive in contacting families each month to see how things were going, how's the system going, does there need to be any changes? And in part, I think because of that, you see that the systems were tending to be used more consistently in amongst the more subsequent samples that we were enrolling. So you see over 12 months, you had 11 people complete up to 1 year of data, 10 of them were still using the system after a year. And then you see something similar at 6 months too. So these are the review checklist items. And again, we're not going to spend time going through each item, but again, this is on a 5-point scale. 1 is strongly disagree, 5 strongly agree. And I don't know about you, but when you look at these data, I don't see it to me, it doesn't seem like the system was received that positively. You know, usually as a rule of thumb, I'd like to see scores over 4 on some of these items or many of these items. But by and large, for many of the items we were looking at, you know, I would say it was moderately received at this point of the study. In terms of some of these lower scored items, these were negatively worded items. But for example, I felt lost using eNeighbor. Most caregivers didn't say that. But when you look at some other items that you would hope would be higher, for example, eNeighbor was easy to use. It was under 4. The sensors of the eNeighbor system worked well. It was under 4. After using eNeighbor, I feel like I now have access to a service that looks as though it will meet my needs. Again, it's under 4. So you can kind of see there's this trend of, I would say, lukewarm, good acceptability, utility, but not overwhelmingly positive.
And Joe, the highest one looks like the assessment by person.
Yeah.
So that's kind of.
Well, that tells you something, doesn't it, Sarah? And I think you'll see in our results, something that really jumped out in the qualitative data too. It's this issue of, well, I'll just jump to my conclusion anyway. Yeah, no, it's a good question. It's an important question. Is when you see these technologies and how they're marketed to families, and there's a good example of this. A couple of weeks ago, we have a conference called Meeting of the Minds in the Twin Cities. Mayo Clinic and the Minnesota North Dakota Alzheimer's Station put it on in St. Paul. Big conference. It's probably, I think, 1,000 people attended. A lot of exhibitors and professionals, but many family members of people with memory loss too. And I was asked to give a couple of talks on technology and aging. And in the room, it was a big seminar room. In the room, there was also this new service featured by Augustana Care called the Augustana Learning Lab, where they literally had 150 technologies out for people to consider buying and using. And the Augustana Learning Lab, to its credit, is there to provide education to families to help them make the right decisions. But one thing that I think was really interesting about all of these technologies, Sarah, is how many of them are kind of based on a plug-and-play premise. You get it, you use it, you put it into practice, it'll work for you. And that's how it's being marketed. That's how it's being sold, essentially, to families. This study, and I think many others, including those controlled evaluations of RAM, where the alerts are going to a person, a third person who's intervening, suggests the importance of having this human mediator for these technologies to actually work effectively. In this study, the alerts are going to the caregivers themselves. There's not this third-party intermediary that can kind of maybe better act on the information that's provided, better intervene. You know, Katie?
I may have missed this, and I apologize
Yeah.
if I did. Did the caregivers live with the person with dementia?
Not always.
Okay.
No, it was mixed. And that,
I'm wondering, what were their expectations going in? Did they think this would replace them having to be there as often?
I think for many of them, it helped them feel a better sense of mind and security. It varied so widely by home and the home arrangement. But in some cases, even though a caregiver would be living with a care recipient, the care recipient might be in their own space, like downstairs in a basement, and they wanted monitoring at night.
Yeah.
They wanted monitoring of certain doors or areas and such. And to the credit of this system, it can be customized to meet some of those needs. And that's why these families felt this technology would be helpful and useful.
Yeah, I was just wondering, like, some of the scores why it was tempered is that they don't want to have to move mom in, and this isn't quite getting there.
Right. So, and you're going to see more of this in the qualitative presenting. Now, this, and then in the second study, this living with caregiver, care recipient emerges as something important to look at too. In a way I kind of didn't expect, but it was interesting. So one of the things that we did find, to your point, Katie, we included living with caregiver and a bunch of other variables, and we correlated it with the RAM review checklist scores overall, and at 6 months, and none achieved statistical significance. So we didn't find anything there, okay? Now again, it's a small sample. There might not have been much happening in that regard. But then when we looked at the qualitative data, we started finding, I think, much more dynamic process going on in how families were using this technology. So this is that case-oriented merged analysis I was telling you about before, where we identified 3 cases and we basically linked their RAM review checklist score with the qualitative data we provided at the 6-month checklist, 12-month checklist, 18-month, and then finally their semi-structured interview. So this is this case, this dimension, was somebody who was highly enthusiastic of the technology and stayed that way the whole time. So you can see their scores overall, the average scores are pretty high on the review checklist, close to 5. So I'll take, for example, I'll look at the exemplar quote after the semi-structured interview. It's just been very helpful, and it's made us confident that we can set alarms so we can get called at night in specific situations. So again, we feel like we're being proactive. We're aware. We're going to be notified. This is a very kind of engaged family. They actually utilize the dashboard information, so they go on the computer to see the activities going on and such. So they were using this to the best, really probably in an optimal manner. And that was reflected throughout the study. You know, in general, at 6 months, I feel better about the coverage we are providing to our loved one. I feel we're doing a better job of monitoring the situation without being too intrusive. So again, you have in this case, and in several other cases in the sample, kind of high enthusiasm. Then you had instances where there was basically low to moderate enthusiasm throughout the course of the project. So this is an 81-year-old woman caring for her 82-year-old husband. Again, you look at the review checklist scores, they're pretty bad. They're not really good. I mean, they're under 3 or under. So what did you see here? False alarms. I set off the alarms myself, forgetting they were there, and became very frustrated. Didn't use the alerts that much. Didn't think I could answer this. I probably don't need it, since wandering did not become an issue. Did not think the person's memory loss needed much monitoring by the end, since I'm not in the house. Not like if the person is living alone. So you got a sense here they weren't really engaging with the technology. I think they became frustrated initially, and then they just stopped using it pretty much. So there were a number of caregivers in this category over time, the slow to moderate enthusiasm. And then finally you have, and these were the most interesting, and were this group of caregivers that we can call adaptation acclimation, where they started off not really liking the system, but then for various reasons they felt the system was working for them. So at 6 months, this gentleman was an interesting gentleman. He was living with his 90-year-old mother in a trailer. And so he was getting very stressed out because his mother was right there all the time. You know, he couldn't get away. So initially he got a lot of false alarms, and it was really starting to stress him out even more. Okay, I was lucky. I was happy he still stuck with the system. So this kind of happened over a period of time. But then what happened here, and it's reflected in these quotes in the later stages of the study, he noticed that the toilet sensor was going off with his mother multiple times. And so what he did is he felt something was odd, so he took his mother to the doctor, and then he found out she had a UTI. You see, so this is an instance where the system actually worked and helped kind of address a potential problem that could have really exacerbated something worse if it wasn't there. Okay? So again, an adaptation kind of acclimation trend in this particular case. Now, because time permits, I would love to show you, and I have them at the end of my slides, the other quotes we collected over time in terms of our thematic analysis. But instead, I can't show you the quotes per se, so I'm just going to show you the themes that emerged, the categories and themes that emerged in our qualitative analysis of all the checklist open-ended data as well as the semi-structured interviews. And if time permits at the end, I'll show you and we'll read through some of these quotes that reflect these themes. The fit of RM and how important the context is for this technology to actually work and be seen as acceptable. You know, some of the themes that emerged from this category just didn't fit my caregiving situation or may fit others' caregiving situations. This idea of taking time, which you saw in the case-oriented merged analysis, of how to really iron out the false alarms, and then the importance of staff support, which came out a lot in the qualitative data too, to the point that Sarah made earlier. The big thing we had to do and work on was, again, this idea of you can't just plug and play a system like this, because it was leading to so many false alarms initially that families weren't engaging with the technology effectively. So again, we had to work with Sharon to ensure that families could get acclimated to the system and reduce these false alarms that were occurring. Then, caregivers did indicate a number of benefits, which you can see here. Promoting peace of mind, was easy to use, prevented some health crises from occurring, and then promoted independent living. In many instances, families desire to keep the system. The way this works in our study is the grant pays for their own activity monitoring technology for an 18-month period. And then at the end of that period, families can choose to purchase it if they wish. And they get it at a discount because we've already purchased the sensors themselves. They just have to pay a monthly connection fee. And we found for a fair number of caregivers that they've decided to keep the system if they still kept it through the 18 months. And we even saw that in this earlier feasibility and utility analysis. But again, there were many drawbacks as well and recommendations for improvement. Some of these we've already kind of covered. Families felt the online dashboard was overwhelming. They didn't know how to act upon or even utilize the information, which I thought was a key point. We talked about the disruption and potential intrusion of these sensor systems, technical difficulties that occurred, and then finally desire for more help with getting the system set up and then managing it over time. So what are some of the key discussion and implication points of this first study? We've already talked about this issue of plug and play and how important it is to have this third party as providing ongoing consultation and assistance. The importance too of understanding acceptability and utility in over time. I think many of the pilot studies that I've read, the studies that I'm familiar with in this space that have tested feasibility and utility of remote activity monitoring technology tend to be a very short time periods. And that doesn't really reflect the changes that are occurring in dementia, which is really important even at acceptability and utility, because things are changing quite a bit for people with dementia in terms of adverse events or other things. Can the technology adapt itself to help people in those situations? I think that's really, really important. That's been a missing gap. That to me has been a real gap, even in some of these feasibility studies. It's possible too, when you're thinking about putting a technology like this in the home, you know, you're talking about a lot of diversity and heterogeneity in terms of, first and foremost, of the physical environments. And you heard that here. We had one case person living in a trailer, another case a person's living in a 4-bedroom house. You know, the list goes on and on. Is the system adaptable enough to not only work in various home environments, but then also adapt itself to different caregiving situations, such as when you have instances where the caregiver is living with the care recipient or not. So again, are these systems adaptable and flexible enough to address this heterogeneity? Remember, a lot of RAM technology studies and a lot of RAM technologies in terms of how they're deployed tend to be deployed in what I would argue fairly consistent environments, in that they tend to be of long-term care settings, residential long-term care, assisted living apartments and such. Granted, I know there's a lot of diversity in those as well, but nothing close to personal homes. So, all right. Let's move to study 2. And again, if we have time, yes, please, Sarah. Yeah, definitely.
So I might have missed what you said, how you measured the caregivers, how
Yeah.
that maybe plus their age or something could be very different.
Yeah. You know, that's a good point. For our study, the comfort with the technology and such was not done systematically in terms of a measure, which, in retrospect, I should have included. It was really done vis-a-vis the needs assessment that Sharon Bloom conducted, and then through, I guess, these qualitative elements where we kind of can determine if there's discomfort with the technology, why. But we didn't have, even though those measures do exist, as you note, we never assessed outright the degree of comfort with the technology to begin with. That's definitely a limitation, and it comes up in the second study too, as you see. Okay. All right, so I wanted to move to study number 2, which again, I wanted to go back to this diagram of the parent trial. Again, recall we're hoping to enroll up to 200 family caregivers and people with memory loss to follow over 18 months. So we decided, for a couple of reasons, to consider taking a look at the 6-month caregiving outcome data. Now, the caregiving outcomes aren't the only outcomes. We're looking at a number of person with ADRD, health service use, and cost outcomes too. But we made a decision to potentially look at these 6-month outcomes. And there was a couple of reasons for it. Let me first say why it's wrong to do this, okay? And why maybe I'm naive or bad or whatever. And if you think that, I'm sorry, but. So the first thing is as many of us know who are steeped in traditional clinical trials methodology, you should never look at your outcome data before the trial is done. It certainly increases risks for type 1, type 2 error, p-hacking basically. And I think David introduced me to a really interesting paper by Council that came out in 2017 where they actually did a review of preliminary outcome analyses. And what they found, I want to say it was 90% of the papers they reviewed, they tended to overstate the treatment effect when they did these preliminary outcomes. So in addition to type 1, type 2 error, you're also increasing bias, of course. I mean, the bias of, looking for a positive effect. These are all problems and they're gonna have ramifications down the line for us. So when we actually look at the caregiving outcomes again at 18 months, I'm gonna have to statistically adjust for that, basically using conservative p-values and other types of methods, which will hurt us in terms of determining significant effect. So why would I do this? Why would you bother doing this, Joe? Here's why. let's think of this meeting of the minds conference again. I can't tell you, when I talk with families and others, how desperate they are for information on, will this technology work for us? And when you're working in the technology space, the development of these technologies are such that by the time, if I waited till the end of the trial to even look at some of these caregivers, this technology is probably going to be obsolete. Now, I was utterly naive when I put the proposal in initially to address any of these things. I didn't really even think about it. But I guess it's a lesson learned for those of us or those of you who are going to be doing work in this space of the need to basically prepare yourself for doing these types of preliminary analyses, in part to address this technology development curve. Okay. To me, the bigger driving concern was I wanted to get information in the hands of stakeholders that simply isn't existing right now. Really, who's filling that void are the product developers themselves, and it bothers me, quite frankly. Certainly the mission we have with our research is kind of steeped heavily in community engagement with these families and being an honest broker for them. And I felt like we wanted to do this analysis now in order to achieve that. And a lot of it was inspired by this communication with families themselves. I made the decision to do it. Okay.
Sorry.
Go ahead, Sarah.
But would one way of solving the conundrum be to have, in the future maybe, to write that the immediate outcomes are the primary outcome?
Yeah,
and
yeah.
the other ones exploratory?
Yeah, that could have been, perhaps. I mean, I would have to, consult with someone like David or other methodological experts. Probably what you have to do, David, is you have to power it in a certain way to be able to accomplish these preliminary, outcome analyses and then related to parent trial, right? Maybe.
Yeah, I mean, you described an important issue. I mean, you could probably should have a future session about, how we, we're trying to evaluate these kind of behavioral interventions based on, big pharma rules about randomized trials, and it's getting worse, not better, in terms of clinicaltrials.gov and all the things you have to promise that you will do and not do. So I don't know. I mean, I think.
I think, you do your best you can a priori, Sarah, and probably power the study, maybe look into some of these adaptive intervention design approaches, something, because I've seen certainly in the child psychiatry literature, some pretty exciting models that way. And I want to learn more about those. I don't know as much about them too. Even with that in mind though, when you're doing a mixed method study like this, and you're going to see what happens, and as I move on to study two, because of the nature of qualitative data and analysis, it's emergent. You can't predict what comes out of the qualitative data if you're going to use that to inform subsequent analyses in your quantitative. That's what happened in this second study too. That's a further complication. Crespo doesn't talk about that at all either. So that's something I myself am going to have to think about more carefully too. Because you can't limit the qualitative data in such a way that it can't do what it's designed to do, which is explore process, explore more. But if you want to do mixed methods, which in the end, remember, mixed methods is integrating quantitative and qualitative data in some way. The easiest way oftentimes is like we did in study one. You have quantitative data, you have qualitative data, you compare them both, do they look the same? Like in the results or discussion section. Or, you can do it in a sampling way, or what you can do is you can quantify qualitative data and then plug it into a quantitative analysis in some fashion. You're going to see an example of us doing that here. This wasn't a priori because I had no idea knowing that this would happen. Yeah. So again, I'm putting myself out there for all your criticisms, and feel free to email me after.
Well, I think another point, to Sarah's point though, even 6 months.
Yeah.
You also want to analyze the data even before you have the whole sample at 6 months. You want to do a preliminary analysis. Right. So it's not that this is the last time point. It's that while you're still doing the study.
Right.
Yeah.
Well, and the qualitative part, some people would say is almost an intervention.
You could say it, yes, definitely. Certainly. Now, I guess in this study, one thing we tried to offset that, Sarah, is remember the initial qualitative at 6, 12, and 8 was really in the survey. Well, I guess, there are examples of writing interventions that are considered, I don't think the level of text and depth, I don't think was interventional for the caregivers in this case. But, and the semi-structured interviews are done after they're done, with the study. But you're right. No, I mean, it's definitely an intervention in and of itself. So that's a good point. So again, we made that decision to look at these caregiving outcomes at 6 months to see what was happening, to see if this technology was actually basically living up to the claims that many others have said it can do. So here you can see our participant enrollment flow for these 132 families. Again, this was as of November 30th, 2017. We had 132 family caregivers who were to provide 6-month follow-up data by that date. Okay, so you can see we had a lot of outreach to individuals, 536 individuals over time. In some cases, we have both the primary caregiver and then the secondary caregiver who wanted to complete a baseline survey, so we included them as well. And then you see here basically how the final sample came out at that 6-month period. 64, and again, we're only including the primary caregivers here. 64 treatment participants scheduled to complete 6-month follow-up, and then 68 controls. Yeah. So it just gives you an idea of the study flow. Yeah.
How are you advertising? So what's your catchment sample?
Yeah, so really it's the entire state of Minnesota, and then also Wisconsin as well, like kind of bordering areas of Wisconsin. So we started with the registry. We have the University of Minnesota Caregiver Registry. Then also we would advertise via community outreach efforts in terms of, when we do a lot of community outreach and educational presentations. We'd offer caregivers the opportunity to learn more about the study, and then newspaper advertisements too, in local circulars, which interestingly enough, I would say had been outside of our registry the most successful approach, particularly for the rural families. Yeah, that we've gotten a lot of good traction. This has been a real bear study though to recruit and enroll for. It's not been easy, in part because of the idea of, we all think, oh wow, technology will be so exciting, everyone will like it. And a lot of these families, I mean, they see the need for it, but it takes convincing. Particularly the idea of putting something in my home. I don't want that. So it took some time to work with families to help them understand what the goal of the intervention was. Okay, so for the second study, fairly simple analytic approach at this stage. We had 6 months of data. So we started with, we basically conducted a series of repeated measures of NOVA. Again, if you recall, our main hypotheses here were the technology would result in significant improvements in caregiver self-efficacy and competence, and then reductions in caregiver distress. Okay. This was mixed methods again. So in this instance, because again, recall we're only looking at 6 months of data, we then also took a look at and qualitatively analyzed the 6-month RAM checklist data available. So by the end of November, we had 49 completed RAM survey checklists in this particular sample. And again, the question that our qualitative methodologist sought to answer was, what made a difference in how RAM was received by participants? Okay. Then the other thing we decided to do, and this is where the mixed method piece come in, and this is where I wanted to integrate the qualitative and quantitative, was if the qualitative data identified factors or other dimensions, constructs that seemed to be linked to how well RAM was working or not, we then went back to our quantitative data to see, did we have matching empirical variables, quantitative variables that we could then conduct a follow-up analysis, a moderational analysis, where treatment by this variable or these variables would be kind of used as moderators. To see if, for example, living with the caregiver moderated the effectiveness of the RAM technology. Dementia severity, et cetera. You're going to see some examples of what those variables were, again, based on our qualitative analysis. But this also makes it, these are post hoc analyses, admittedly, but you can see why this makes it hard to ever predict this. I don't know what the qualitative data are going to say or indicate. So the results of the repeated measures ANOVA, and I guess you can't call me biased in this regard, because again, if you recall, the council paper showed mostly preliminary trials. They tend to overestimate treatment effects. As in fact, at 6 months, RAM didn't have an effect on any of our caregiving outcomes. And in fact, when we looked at the treatment by time interaction effects, there was no significance, but there were some time effects, which I highlighted here, that were significant at the P.05 level, but in ways you wouldn't necessarily expect, where burden across the sample and depressive symptoms across the sample actually increased from baseline to 6 months. Not by treatment though, so it wasn't probably due to whether they had technology or not, but for other reasons. Okay, so that's what we found here. So right now, null findings. Nothing's happening. In and of itself, I think would be important to present and report, again, for the reasons I described to you, perhaps too passionately, but I mean, that's what I believe, So here's the, and I tried to put this on the table, the qualitative results. So what you see here, where in the middle column are the themes that the qualitative analysts identified. Time constraints and stress level, comfort with the technology, care recipient behavior, dementia status, and living arrangement. These were the themes that emerged from the qualitative analysis. Again, trying to answer this question, what seemed to determine whether RAM was well received and worked or not, at least based on these family caregivers' perceptions. So you can see some of the quotes that came out of the checklist that kind of help describe these scenes. So you look at time constraints. I haven't received alerts and have not been able to go into the data. In all honesty, I've been consumed with significant health issues with my mother, and I just haven't had time to do this. This came out multiple times. So the variable we felt that could best reflect this, the closest thing we had in our data was work status. So we included that as a moderator in a repeated measures. Comfort with technology, it's easy to use if you have familiarity with it. I like that I can check the system on any internet-connected device. Clearly, if we had this variable, we could have included it, we didn't. But that probably would have been a pretty powerful moderator, I would imagine. Then you see a variety of care recipient characteristics. Dementia severity in particular came out in the qualitative comments. The care recipient hasn't progressed in the disease to require the monitoring. Emergency alerts attributed the person so far into dementia. So clearly dementia status is playing some kind of role. We don't know what, so we included that as a moderator too. And then in addition, ADLs, IDLs, memory behavior problems. And then finally, whether the caregiver lives with the care recipient. I didn't use it simply because it was time consuming to handle what I was up to. And since I live with my mother, I didn't feel like I needed to know her movements. These are all variables that might have been impacting the eventual effectiveness of RAM. So what did our three-way interaction show us? So these actually did come out to be statistically significant. And the ones most important are these on the left-hand side. So first, a three-way moderation, or pardon me, not the left-hand side, this one on the upper right-hand and lower left-hand side. So let's look at the upper right-hand side. This is interaction with cognitive impairment. Basically, it's a measure of dementia severity. We dichotomize these variables to the upper quartile and lower quartile. If I recall, I have to look back at that. Forgive me. But basically, we basically categorized the dementia severity variable. So what you see here in terms of the lines, the solid lines are those that receive remote activity monitoring technology. Black means it's the high score of the moderator. Gray is the low score. So to basically put this in a nutshell, if you look at interaction with cognitive impairment, those who were caring for somebody with low dementia severity indicated increased self-efficacy over the first 6 months. And it also received the RAM technology.
Can you say that again?
Yeah, I know, it's kind of tricky to speak these out, isn't it? So caregivers who received the RAM technology and cared for somebody with lower dementia severity, so earlier dementia trajectory, indicated higher self-efficacy over 6 months. Yeah, so that's what you see. Here, you see something kind of interesting too, in terms of sense of competence. And competence in this case is competence in dealing with the loved one's dementia and the care demands as a result of it. Here again, caregivers who were caring for somebody who had difficulty navigating the house, wandering problems. Caregivers who cared for those who had wandering issues and used the technology reported increases in competence over 6 months as well. I included this one on the left-hand side because this was not a significant three-way interaction. It was a significant two-way interaction, but it was still kind of interesting. Getting with the living with the caregiver. Basically, care recipients who lived with, or caregivers who lived with the care recipient, regardless of whether they received technology or not, also reported increased competence, which I thought was kind of interesting. I can't explain why, but that was an interesting finding. But really, in terms of the three-way interactions, you see here effects on competence and efficacy that are occurring with the technology in these particular situations. Okay. So again, this to me is an example of where you can use and leverage mixed methods to help you dig into your results more. I don't know if I would have necessarily thought of some of these moderators ahead of time to consider as potentially influencing the effect of the technology on key caregiving outcomes. In this case, efficacy and competence. Okay. This more or less summarizes what I talked about earlier about weighing the costs of a preliminary effectiveness analysis such as this one. I did want to point out this quote here too, which was another thing that just came out recently, but was really important to me. So this was a really good policy analysis by Barrage that came out, I think last month or the month before, about how Medicaid has now emerged as the largest three-party payer of RAM technologies. So I think I want to say in either 19 or 21 states, Medicaid will pay for these technologies. No needs assessment being done, no kind of attention to consent or anything. So it's kind of the Wild West. And Barrage's conclusion here is decisions about Medicaid reimbursement of technologies that have the potential to dramatically alter the way older adults receive supportive services are being made without research on their use, social and ethical implications or outcomes. Again, that is why I felt it was acceptable to proceed with this analysis. in these results. So when we think of some of the other implications of this work, clearly the deployment of RAM is critical. We talked about the importance of perhaps having a third-party individual, such as a care professional, really be the entities interpreting these alerts and then acting on them versus them going to family caregivers. But nonetheless, I would also argue the way we looked at RAM in this study really is going to probably reflect how RAM is going to be used in real-world situations. This is probably how families will purchase systems like this in the future and more likely than not utilize them. And if you look at, again, Google, Best Buy, many of these technologies are available right off the shelf now. And this aligned with our earlier acceptability and utility results. These initial months spent calibrating and modifying the system to meet the needs of the persons with ADRD and the carriers are probably the ones that are the most challenging. Of course, when we get fuller follow-up data, we'll be able to look at this specifically. But clearly, we saw this also in the qualitative data of these initial 6 to 8 to 9 months of how challenging it is for some families to really figure out how to use this system. What the mixed methods findings allow us to do is to find the situations where these technologies may be most effective, which I think is important information to have, not just scientifically, but perhaps for consumers and stakeholders as well. And we saw that with, for example, difficulty navigating the home, and also in terms of dementia severity, particularly earlier stages, where use of this technology can really help caregivers improve their self-efficacy, enhance their feelings of competence. Again, I think we've been talking about this through a lot of the Q&A here. One last point to make on this is thinking about conceptualizations of theoretical frameworks. I've fallen back on the stress process model in part because this is a dementia caregiving study, and the stress process model is a conceptual framework to describe how stress proliferates again in that context. But again, when you're thinking of RAM, you're thinking about the context, the home context itself. It might be additional theoretical frameworks need to be considered, if not integrated with the stress process. Well, certainly the first that comes to mind is person environments, but probably many others too. Thinking about how technology can help one overcome environmental press, for example. Limitations in this study, I mean, we've been through many of these already. This is not a blinded study as well, and I can explain why. So AHRQ, for those of you that have received AHRQ funding, know they cap their R01s. So at the time when I got this grant, which was 2014, it was capped $250,000 total. So I have to make a decision as a PI, okay? I either have the caregivers buy the systems themselves, or we purchase the systems for the caregivers, and I basically act as the RA and research coordinator for the first 2 years. Because by year 2, we could afford to purchase enough systems where then I could hire a coordinator and such to do that. I chose, obviously, buying the systems because there's no way caregivers are going to say, yeah, great, I want to be part of the study, I'll pay for the system too, which costs around $5,000, probably in total over time, $4,000 over an 18-month period. So because of that, I couldn't blind myself. Okay, I mean, I wish there was an alternative, but there wasn't.
Sorry, Joe, can you recycle them, like when someone finishes the study,
Yes.
someone else uses it?
Yeah, and that's what we're doing. So what we did was, so again, the goal is 200 family caregivers, 100 in the treatment group. We purchased, I believe, 50 of the sensor systems that can be recycled and reused. Yeah.
And then you give you a break on the price?
They did actually. They gave us a break. And the other thing they gave us a break on is what we had in the budget was the purchase of the sensor systems themselves, not the monthly connection fee. So we were able to offset that both with the grant, but then Health Sense and Lutheran Home Association were able to offset that if needed too. So yeah, we did get a break in that. Some other things here, certainly you can make the case if you're a qualitative methodologist, using the open-ended responses in the 6-month surveys is not necessarily giving us utterly rich qualitative data, but nonetheless, I think it was informative in the context of this study. Okay. And this point here was a limitation, exactly what you said before, Sarah, about the comfort with technology. Okay, I can stop here. I can certainly show you more of the qualitative quotes if you wanted. We can leave early too. I mean, whatever you'd like to do. So gift of time is good too. But
Control group was a no attention.
Yeah.
This is so cool and just so exciting, and I can't help but think both from a caregiving personal perspective. With my dad who had a stroke, we put cameras around. Yeah. And so all this psychology of him feeling watched and every day, throwing it out, turning the camera around because he felt like we were spying on him. But from the caregiver perspective, and I think also I work with faculty members who use Epic, so like medical record and all these data.
Yeah.
It's just not enough to throw more data at caregivers or faculty members who have limited time. I obviously know dad's, situation negative, prognosis negative, things are bad. So the fact that I have a technology or a tool to show me, hey, the situation's bad, it's getting worse, and I don't have that, I don't need that extra evidence that things are bad. What I would love would be for my technology to say, as you start talking about deployment, that those data are going to someone who's going to then do something. So it's one thing to have my refrigerator tell me you're out of milk, thanks for giving me more to do, or you're tired, your right tire needs air, or dad needs to go with UTI, but geez, we saw this, the milk's in your refrigerator, the guy came over and filled up your right tire while you work today, and the nurse is changing dad's prescriptions in order. I mean, that is like, that's a whole different situation versus giving me more data.
So I think you got a central lead here on my talk, is I think for these systems of work, having that intermediary that knows how to act on this information that's being provided in a way that's clinically effective and useful. To me, that's the issue. That's an issue. Maybe not though, because let's think about this. So think about rural communities, and care managers in rural communities who can't possibly serve the people they want to serve because of the geographic dispersion. There are many adults living out there with memory loss that are likely isolated and such. Could a system like this offset, at least in part, substitute maybe care management in those contexts? Could be. Certainly if you look at the Finch paper, the one that came out in the Journal of the American Geriatric Society, they make the case that even with the third-party care manager, costs were reduced sufficiently to make it. They really look at cost effective. They make that case that look at reductions in hospital admissions, et cetera, by using the technology this way. But that paper was kind of funky though. It was weird to read because they kept saying we don't have enough power, we don't have enough power, we don't have enough. But then they just did bivariate analyses with like a sample of 240 people. They have enough power. I don't know why they weren't getting good values, but maybe the findings were clinically meaningful. I'm not sure. But I think you're right. It all comes down to me. Technologies can be as fancy as you like, but is the information usable? And I think HealthSense and these companies are trying to move that way. But again, a lot of these developers, they don't necessarily test these products with you, with families, or even with direct care workers. Because I know for a fact there are staff in long-term care that they have these monitoring systems. They don't pay attention to them. Sometimes they don't respond to them. So how do you make these things work effectively clinically? And I think in order to do that, you need to have studies that many of you can do, I try to do, that try to get at that and answer these questions.
And that's why it also makes you understand, as creepy as it is, why Alexa is listening into our conversations, because it's almost like they're trying to get more data, or how do people use things, and what questions are they asking? So I can kind of understand why, when you Google something, just the mere question is feeding information into the big brain trust that says people want to know about this stuff. So let's figure out how to drive tools to engage with people. Every day when I don't even know how it happened, but I get these emails once a week saying, how to use your Alexa thing. I was using your Fernate timer, set the timer for 6 minutes. I had no idea. I could ask her to play AM 1230 or what the temperature was here. I had no idea until I started opening up those emails going, did you know? No, I didn't. Thank you very much.
What would be interesting to me is this, See, it's funny you mentioned Alexa, because at that presentation, me and mine, I met a gentleman, and he was talking about how he used Alexa, and he loved it for his mom with dementia. He was using it and deploying it, kind of using that, because she could ask for things and stuff, I want to call X or want to do Y or Z, and he was able to use it effectively. Which leads me, maybe we approach this from the wrong lens. We're saying it is, okay, the product's been developed, or we're engaged in the development, now we're going to evaluate it and stuff. But I know, and I've talked to many families and caregivers, they cherry-rig and utilize technologies in ways we don't even kind of, and I'd love to maybe it's you go it from the opposite direction. You ask families, how have you used technology? What have you done effectively? Because I've heard of people using baby monitors, I've heard of people using all kinds of different technologies. You wouldn't think like, wow, I never thought of using that. That was pretty creative, and that might be useful too.
Imagine a study where I've always loved to have some smart like sixth grader, follow me around all day.
Yeah.
And say, you don't need to click here or do this or think that. And I go,
Yeah.
who knew that at the elbow kind of assistance
Yeah.
with faculty members using electronic medical records,
Right,
but
right.
also at the elbow people in the
Right, smart
house
home technology.
just hanging out
Yeah,
to see at the end of a week, when we've identified 10, 15 possible ways that you could, smart solve this issue. I think something similar to
interesting.
watching how people
Alexa,
do
I think
stuff.
somebody at University of Maryland is doing something with Alexa too.
Oh, really?
With
Okay, I'm sure. Yeah, I would be
caregiver.
surprised. I would be surprised. That's kind of interesting.
Hey,
George is a student too.
Oh, okay. Yeah.
Great talk. Just want to go back and pick up on a point that Katie raised earlier
Yeah.
about family expectations around technology. There seems to be sort of general logic about technology that in the short term, we tend to overestimate things.
Yeah.
Right? And particularly commercial developers, we talk about them filling the void and we kind of hype the product and hype its potential. But then, in the long term, we seriously underestimate the
Mhm.
impact of technology.
Yeah.
And, often this sense of, overpromising leads to this sense of disenchantment, people reject it, and then, but yet, how do we keep people sort of engaged in using this and see sort of a very long-term impact, even though there's lots of barriers along the way.
Yeah.
And, we have to sort of monitor at population level sort of what's happening with these technologies.
Yeah.
Maybe even a little improvement, when you leverage it across the population, may
Yeah.
result in big cost savings.
And yeah, I agree, George. And maybe that does kind of play into this idea of it's less about deploying a technology and evaluating it, like you say, from a population standpoint, seeing how technology truly is used in caregiving situations. How are families, how are they using their iPhone effectively? Are they doing other kinds of things? And maybe that's where we start. So it's more, maybe I am or not on your wavelength, George, but it's kind of less deductive and more inductive. Yeah, I mean, that's, maybe it's mixed methods coming out of me again, but I mean, that's what I'm thinking, so, yeah.
It's interesting, I'm just kind of sitting in and listening to this.
Yeah.
I'm not a scientist, I'm an investor.
Oh, interesting, okay, good.
Aging.
Yeah.
Directed technology.
Interesting,
And
yeah.
Many of the startups that I see developing tools to use to serve this market, they focus only on the technology.
Mm-hmm.
Overlook the user experience, they overlook the education, they overlook how well this tool fits into the workflows of caregivers.
Yes,
healthcare
yes,
providers,
yeah.
And the way people are living their everyday lives.
Yeah.
And they don't start with a problem that somebody has and trying to solve that problem, which is as much the process of using this technology.
Yeah.
And I see cool technology that people don't know how to use. When you talk about Alexa, I've read about studies that people are using, trying to figure out how to use Alexa in senior living communities. And
Yeah.
I think because you've got a deep-pocketed corporate partner, they spend an enormous amount of time teaching people. And the truth is,
It's a good point, yeah,
even though
really good point.
people give credit to Apple and Amazon for creating kind of intuitive products, they're not. And particularly for people who might have cognitive impairment
Yeah.
and for overworked
Yeah,
caregivers, if you're not going to worry about how you teach them to use it, and then you make life simpler and you solve a problem for them, you're just peddling bright shiny.
Yeah, and so I think in this case, there's a real risk of, thanks for attending, by the way, great perspective. And yeah, I think you saw that in some of the study. I mean, you saw it certainly with this kind of technology, and part of the reason for the title is, in many cases it is another stressor, and then, it's not gonna work.
And it's funny because
Yeah.
here at Baltimore, there are people working on these startups, and we keep saying,
Yeah.
you ought to be partnering with the two world-class
Right,
institutions here in Baltimore, and I think people are kind of scared off. You made a great observation about if it takes as long to do one of
Yeah.
these studies as people expect, because it's technically a medical device, they're afraid their device will be obsolete by the time there's any result. So but we got to get people to say that if you don't get evidence that it works and produces improved care, lower costs, improved quality of life, then nobody's going to pay you.
Yeah, you're so right, and the Twin Cities is kind of a booming medical tech market. And I have had multiple meetings with, new companies wanting to talk. They hear I'm doing this and, might have heard one of my talks. And it's kind of a very similar conversation every time where they're kind of in the space where you're saying boy, technology's cool and all of this. But you start asking basic questions about how do you envision working with this for somebody with memory loss or X, Y, Z. Those things aren't thought about. But there's a flip side to this too, is we as researchers should also be thinking of creating infrastructures to support this better. Right now, it doesn't always have to be a randomized controlled trial that takes 7 years. There certainly are designs and approaches and methodologies that can be used that maybe, again, aren't going to help efficacy, maybe not effectiveness, but can help developers better understand barriers, challenges to what they're doing and to refine it effectively. And one of the things, so I have a colleague in the primary medicine at the University of Minnesota. He put in a large center grant. It was like called one of those E54 grants. And what the goal was, it was a really good idea. He didn't get funded, but we were part of that. Was he was going to create an infrastructure where a company who's developed new technology can come to the University of Minnesota, and basically they can go through like a multi-stage process to refine their technology, understand its kind of feasibility and stuff, and then actually pilot it in a primary care clinic, all like seamlessly. So it kind of gives them that development life cycle where they get evidence, but they're getting kind of evidence while they're doing it. So you kind of see how the research and product development practice, it all was merged together. Now, I don't think it was written as effectively in the proposal, that's why I didn't get funded, but the idea and premise is great though, isn't it? That's kind of what the infrastructure should look like.
You and I talked about it a little bit
Yeah.
before. We go into even researchers, we go into assisted livings with these bright ideas and hey, this intervention worked, and then the assisted living goes, yeah, but that doesn't work. It doesn't go into my workflow. It doesn't match with my, the computer system or whatever that our data input system that we're using. And it's the same thing. Technology is going to them saying, hey, I've got this great thing.
So, yeah, I mean, again, to me, this is a pitch for mixed methods. I mean, in part, not specifically to this topic, but in a larger sense.
Yeah.
This is why having these different methodological tools at your disposal, I think, can help with these kinds of issues.
Yeah.
So David.
As much as it's not funded, that needs survey is an important thing. If you're not talking to them beforehand, you're not gonna develop something that they use.
Right. I think you mentioned in one of your slides that like over 20 states Medicaid is paying for these kinds of equipment and stuff. So I'm getting the picture that they're doing that largely without any evidence base of its efficacy. So how?
That's because someone can make money off of it. No one makes money off of all behavioral trials, right? But it's like a drug or a procedure. Sorry,
well, I guess my sense is that Medicaid is doing it in all these states because they think even if there's not evidence, if there's a plausible reason that this is going to prevent nursing home placement for even a couple of weeks.
I think they think that. I recommend reading that paper. It's actually really interesting. It looks at this from a different lens, but so from my understanding is it's not as if it's like it's separate category that it's like put under, if a care manager, a Medicaid care manager decides to use remote activity monitoring, they basically can do it underneath like a generic LTSS category. So, and you can't even really track if it's being used or how long or anything. It's just basically there that care managers can use it as they see fit. And they have kind of wide latitude to use it as they see fit. There's been nothing formalized, again, in terms of consent, needs assessment, even the type of technology. They can use different RAM types. It's not just one, there's multiple kinds. No one knows what's being implemented, deployed, certainly not whether it's working at any level.
So you said that paper.
Yeah, so I mean, if you,
if
you guys want to, you guys can feel free to distribute my slides.
Okay.
Because at the end here, I put all the references on this link, so you all can get that, and the Barrage is on there. But that, I'm sure you found it. It's a really good paper, and it's a nice also discussing kind of how we view technology and like what it means. It's really good from policy. I was very impressed.
And I can't help but be impressed with the fact that there's so many smart people and nobody has time to do anything. Understood. But I had Easter dinner with my architect friend yesterday, and she said when she went to this new firm working with them, she pleaded with them to go take this engineering course. And they said, we can't afford to have you taking time away to do this course.
Yeah.
However long it is, doesn't matter. my point is she finally got permission to go to this engineering course as an architect, and it enabled her to have a better vision or a lens of understanding her component, her contribution to the work after appreciating this. I'm saying all this to say that nurses, researchers, industry, engineers have to invest the time to do this exchange programs, where there should be some formalized program. You should start it, David, where there's a series of all these people get together to think and to really appreciate problems from other people's perspectives. And not just this kind of plaster on once a year conference. There should be this integrated system of all of us talking to each other over extended periods.
And so what excited me about being part of the U54 is I felt like the University of Minnesota was going to try to build that infrastructure to do exactly that.
Yeah.
So, but I'm hoping
talk about this trans interdisciplinary thing.
Yeah.
I think that's a good project for the Office of Faculty
Make it
Development.
so.
Well, everybody, it's after 5 o'clock here.
Thank you.
Thank you so much.